I won't repeat my title. It's already 2 years within the SARS-CoV-2 pandemic, and 2002 began with some kind of a déjà vu, with COVID cases on the rise in many countries, like never before since 2019. So the coronavirus has now spread in more than 119 countries. So I just wanted to give you a short overview, let you know what are the problems of our hygienic system and of the clinical system. And the spread is all over. The cumulative number of confirmed cases and infections are over 381 million worldwide by January 31 this year. So, and that are the infections nationwide so far in Germany. As you can see here, it's so much like never before. So SARS-CoV-2 is here to stay, and we are on the road to endemic. And at our time, the hope that vaccines and previous infection could generate herd immunity has all but disappeared almost. However, we are waiting for data this year. So, and not least now, the Omicron variant has laid bare the need to live with the disease, but also all variants before. And the question is 2022 poised to add our defenses against the pandemic, yes or no? And for me as a hygienist, the question is, do still prevention and preparedness play a role at all? Or can we only respond accordingly? So how to adapt to emergent variants in the normal hospital setting, in the community setting, and so on. That's just an overview of the distribution of the coronavirus variants of concern in Germany this year and until now in January 2022. As you can see, it's Alpha, Delta, Omicron, and so on. And in December this year, in December last year, we found the new mutation or the new variant of B1640 and .2 coming from France. And the question is, why couldn't we predict it to be here? Because it's the first case in Germany, or it was the first case, and that's why I would like to present the case report about this case, not only from the virological aspect, but especially from the hygienical aspect and regarding how to interrupt infection chains. So we have this new lineage was created, it was already known in July last year, and it received the name with .2. And it already was identified first in France and in Indonesia and Congo. And the latest case was in France mid-October 2021. So, and our case report was first proof of a variant B1640-2 in Germany. We found it because one of our nurses at the University Hospital working in a neonatal ICU was heavily infected. She had a CT of 12. Due to anamnestic reasons, we found out that she was not vaccinated because of an anaphylactic shock in the past. And the melting curve was suspicious. We talked to our virologist and we said, okay, is it something new? Is it something different? Then the sequencing and culturing began. And then we could state, okay, it's this new variant. Then we asked the Robert Koch Institute in Berlin and asked, okay, do you know from any other case this kind in Germany? And they said, no, there's just one single case some days ago, but I will tell you later. So the question is, always the question for the hygienist is chicken or egg. So we were a bit afraid that the mother working, or the nurse working on the neonatal ICU, how to say, started a nosocomial infection in our hospital with a new unknown variant. And we didn't know, okay, where did she get it from? So the vertical insert, and were there already horizontal infections at neonatals and newborns. And we tested all wards, all employees, all patients, all mothers and dads, but we didn't find this variant again in this biotop hospital and in the biotop newborn ward. So then we asked her, and she said, yes, I have an 13-year-old daughter. She's in a high school class, and she was also infected. So, and then we found out that the whole class, 5B, was infected from the 4th of December. So we saw, okay, it's really an outbreak on this horizontal line. But for us, it's always the question how to identify the index case. So we didn't find the index case in the hospital. So we saw, okay, maybe it started in the high school class, but how did it get there? And the thing is that intra-household transmissions and intersectoral crossings support the spread and the outbreak. So this was the first pupil in this class. That's the daughter of the nurse. And he lived in a huge family. The mother and one daughter were also affected. And the father was tested in November. So we thought he might be the index case for the index family and who started the spread. So the question was vertical insert by the father returning from abroad. And this one was the other case found in Germany, the information by the Robert Koch Institute. And we didn't know, okay, there were any implications that they had contact to each other and who was the first case, and yes. So he was returning from Congo. And the other case was also a traveler. Both were flight passengers. Both came from Congo and they arrived at the end of November. And this father works as a professional well builder. And he worked there in the Republic of Congo for almost 3 weeks. And he'd already developed mild respiratory symptoms at the day before diagnosis, so the day of the flight and the arrival. They performed PCR testing on the 26th of November. And just because of his anamnestics, the virology indicated that maybe the melting curve should, and maybe of a melting curve, we should perform a deeper analysis for this variant. So it's still unknown if both passengers were on the same plane or if they even were sitting close to each other in the same plane, or if maybe both cases are completely unrelated. The next example, it's a family, one of the families, the best example for vertical and horizontal transmission. We have the index family here, and this is one boy. He lives in that family. And that's a brother also. He has a second brother. He goes to primary school. His sister and father and brother number 3 were also infected. Now the next was, okay, also his mother was working in a hospital, but in another hospital, but nevertheless in a vulnerable risk area. And she didn't know that they were infected at first sight. Very interesting is that also the grandparents, although they don't live together in one household, were infected. They had really low CT levels, below 10 almost. And really interesting is all persons have been vaccinated and already boosted, except the great-grandmother. And the great-grandmother also somehow received this strain, although they protected them, they protected her from contacts with all children. So that's just an overview. So you can see that are all cases that have been positive with this variant, but no more. So it, was a self-ending, and it stopped somehow, and we couldn't even explain why the outbreak stopped, or if it even stopped, or if it's still running. The second interesting thing about this was that we saw a prolonged biphasic course. So in contrast to the Omicron variant, we see here for several weeks a positivity, and it starts at the low CT level, goes to a peak, and then falls down again. And the problem is that it's really when the quarantine ends. So we had the problem that the children went to school, or even the parents went to school after almost 14 days. They have been really infectious again. So the same here, family 2. We had the daughter. She was a classmate of the first index case boy. She had a brother at the same school, but in another class, and the mother. And here they started with a CT value of 15, got a peak, and started going to school here. But then it was falling again. So it was just by accident. Then we found this out because I tested them again and spoke to them, because I've known one of the mothers. And even after some weeks, we have been here. And it's very dangerous because not only the vertical and horizontal transmission impedes the interruption of complex infection chains, but also the private labs wouldn't even have been able to identify such strain because they not all perform melting curves. But nevertheless, homogenization of lab methods is not possible. And the fact is that we are too much oriented to the previous variant, so to the Omicron variant. So we shortened the quarantine, and that was the point when the quarantine was shortened. Our Congo patients or Congo persons were really high infectious at that time, or again infectious. So, and we had the problem that the networking was quite miserable because no one wanted us to have a look on this case. And it can really be assumed that there's a high number of unreported cases, especially to this variant. And simply very basic structural measures need to be taken that we can follow and spot a light on cases like this. So what are the perspectives for variants? It's not possible to speculate on virological, epidemiological, or clinical features of this variant. And so far, it's only a low number of cases, and we had this huge outbreak. However, we need to learn from these outbreaks, so that the job of a hygienist, that the outbreak needs to be analyzed, and that we can learn from every single outbreak, that this never will happen again. So, and overall, these observations show once again the unpredictability. And even more interesting or important that these data also warrant the implementation of genomic surveillance of SARS-CoV-2 in geographical areas and at a country scale. So we wouldn't have even been able to identify if there's been another strain in our database. So what are still existing challenges and persisting issues? To be honest, it's just de jure versus de facto. So what's enforced by law and the legal framework? It's almost in total contrast how we need to act and how we do act in hospital settings. So it's a quite gray area of tension that leads to, okay, we have the legal regulations here versus internal policies. So in the last weeks and months, we needed to perform a high degree of adaptation and interpretation that was required. And what what would that be for consequences for hospitals? Yeah, the overall goal is to interrupt transmission within healthcare facilities and to keep our patients and healthcare workers healthy and safe. So most of the legal regulations are not really thought quite to the end. And so, yeah, we need to interpret. And they are not everywhere all experts available there. So there's such a low number of real hygienists who can really decide about, okay, we close the ward, we do this, and who can decide about measurements. We are too low percent of this. So just one example of our interpretation. So the question is, when can I go back to work after infection? Yeah, and when can I perform my free test at the test center? And then we said, okay, you need to meet all the requirements here. And we tried to adapt to the quarantine and isolation regulations in North Rhine-Westphalia. And we mixed all up. And at the moment, or for since when did we decide it? 2 days ago, we decided that a positive CT value greater than 30 is fine. Until the last week, it was 40, because we stated that no person with a result that means positive, independent from the CT value, is allowed to work here. That's totally independent from the legal regulation in North Rhine-Westphalia. And now we shifted it. Yeah. And very important is that in areas with contact with particularly vulnerable patients, that there are special regulations. That's very important to protect our patients. So almost every day we change our flow charts for our employees, because they even don't want to read text. They are not anymore motivated. So there's a huge lack of motivation, and it's not easy for us. Or especially behavior after contact, that they need to have intensified serious testing, because many persons become positive and don't even recognize it. But nevertheless, it's a danger for our patients, or especially in vulnerable areas. So you can see here, it's our current, and you can see that it's just some days ago that we needed to change it again. So even more examples.
Can you possibly wrap up?
Yeah.
Your time is
so
over. Sorry,
how do
sorry
we
to be rude.
Okay, sorry, no, it's fine. I will rush through it. So what are the problems and potential obstacles? As you all know, we have a high degree of heterogeneity in measures, already mentioned. The legal regulations are too much based and focused on basic research and far away from practical applications. And the use of resources is inefficient due to a lack of centralization and coordination. So that's maybe due to the federalisms. And our implication is, it's miserable. It takes too long. We have no adequate communication channels. They're inconsistent, and the standards are fax and email. And we need a conceptualization of biological threat and the implication for public health policy. We need it, and we need concepts not only for this germ or this variant. We need concepts for microbiological agents, for virological agents. So we need it more global, that we can head it over if there's a really strong crisis. So it's all over resilience, and we need a resilient and sustainable healthcare system. So the public health policies, as I said, should not be purely agent-based, but rather really generic to allow transfer of core concepts. We need core concepts and measures for future situations without enacting new policies from scratch. It's very important. So I skipped this because we all need that we know that no vaccine is 400% effective, and that we need a bundle of measures to stay effective.
Once again, can you wrap up, please? We are way over time. Thank you. Are there any questions from the audience? So this is a really frustrating information, because we cannot really do something against such a cross-reactivity or cross-infection, and things will go on. Maybe eventually this leads to a complete infection of the population and then herd immunity. Is this what is going on?
I hope so, to be honest.
What would the other experts say? There's no response.
I can comment on this.
Yeah, please.
I can comment on this. I think finally we will have an infection which will go throughout through the population, and people will acquire the immunity either by vaccination or by infection. The problem is that if you're just infected, and that is also what came out in the questions before and also in my talk, your immunity is not sustainable enough and is not good enough to fight off variants. If you have a combination of vaccination plus infection, that works quite well. But just an infection is the same as just one vaccine shot, at least in our study, and that's not sufficient.